Good evening. This is Sarah Diorsi. I am the Director of Government Affairs for the American Academy of Physical Medicine and Rehabilitation. I am also here with staff Suzanne Butler, Manager of Legislative Affairs for the Academy. We'd love to welcome you this evening to this webinar. As many of you are aware, the AAPM&R continues to be active in the implementation of the Affordable Care Act, which was signed into law in 2010. The law includes the implementation of the health insurance exchanges, also known as the marketplace. The exchanges created online marketplaces where individuals, small employers, and eventually larger employers can compare and purchase health insurance plans. To date, all states have selected a type of health insurance exchange, and these are currently operative in most states. Tonight's webinar will focus on how the exchanges could impact access to and coverage of rehabilitation services. The webinar will also provide guidance to physiatrists on how they can champion coverage of rehabilitation under the exchanges. We have a presenter with us tonight, Theresa Morgan, who is the Legislative Director of Powers, Pyles, Sutter, and Verville, the Powers firm. As the firm's Legislative Director, Theresa is an integral part of the Legislative Practice Group conducting research and analysis on legislative and regulatory issues for healthcare and education clients and interacting with principals in the practice and clients to keep them abreast of developments. She has primary responsibility for the Washington Wire, the firm's weekly newsletter on healthcare policy issues. Theresa has expertise in legislative, regulatory, and advocacy activity regarding Medicare, Medicaid, healthcare reform, the Workforce Investment Act, Rehab Act, and relevant appropriation bills. So now I would like to welcome Theresa Morgan, and I will turn it over to her.
Thank you, Sarah. Can you hear me all right?
Yes.
Thank you. So I'm going to go ahead and get started here. As Sarah said, I'm the Legislative Director for the Powers Law Firm here in D.C. I've been working on healthcare reform issues since about 2008. So prior to the drafting of the bill, during the debate, our firm was very active, as was PM&R. And obviously, as implementation proceeds, we are monitoring and active both at the federal and the state level. Just to briefly go over what the law does, it's a massive overhaul of the health insurance market in the U.S. The insurance market reforms are implemented using the existing state-by-state system. So as Sarah mentioned, consumers now can purchase plans offered in their state, but not a national plan per se. The states select benchmark plans, and then the states retain enforcement authority, although now there is federal authority where previously it was mainly left up to the states to regulate the health insurance market. So the whole strategy behind the ACA is really a multifold. One strategy, one goal of the law is to bring down healthcare costs, and there's a lot of debate over whether or not the law will eventually do that. I'm not going to focus on that goal tonight. I'm going to focus on the goal that is largely being implemented on a state-by-state basis, and that is the expansion of health insurance coverage. So one of the main goals of the bill is to reach as close to universal coverage as the United States can get both pragmatically and politically. And it's a multi-pronged approach in that a lot of stakeholders are asked to help shoulder some of that responsibility. First and foremost, individuals are required starting this year to have health insurance with some exceptions, mainly for financial hardship. And if those individuals do not have health insurance for the majority of the year, they will face a fine at the end of the year through their taxes, and that fine increases over time. For the federal part and for the state's part, there's in the bill the opportunity to expand Medicaid to 133% of the poverty line, regardless of the beneficiary's health status. So that's an expansion of Medicaid eligibility at the federal level that was not required in the past. The federal government will also help individuals pay premiums up to 400% of the federal poverty level. So those individuals who are required to have insurance but who may struggle to afford the premiums can qualify in many cases for subsidies to help pay those monthly premiums. Insurance companies must now guarantee issue and not deny individuals because of costly pre-existing conditions. So that is a large responsibility on the insurance companies. Obviously, it's a lot of risk for them to guarantee issue regardless of someone's health status. And in the past, that was how they avoided risk and avoided a lot of expensive health care costs, was to avoid people with pre-existing conditions, and that is no longer legal in most circumstances. And then large employers. So most of us know that the large employers have shouldered much of the health insurance market, much of the cost of insuring individuals up until now, and will continue to do so into the near future at least. And to incentivize employers to both keep offering insurance and for some employers to start offering insurance for the first time, there are fines that go along with not offering insurance and having your employees instead receive subsidies through the exchange to purchase that insurance. Many reforms actually went into effect prior to October 1st. So many of you know that October 1st was a significant date in 2013 because that's when the health insurance exchanges went live. But there were some significant reforms that were in effect as far back as mid-2010. Some of those include a ban on denials for pre-existing conditions for children. Young adults can stay on their parents' insurance plans until 26, and that went into effect in mid-2010, which means that a lot of plans started doing that for plan year 2011. There was not allowed to be any monetary caps on essential health benefits over a lifetime, starting earlier than last year. The significant premium increases were subject to state and federal review. That went into effect prior to 2013, and that will continue. Medical loss ratio requirements. So these are requirements that insurance companies must spend a certain amount of their profit on healthcare costs and must require a certain amount or must not go above a certain percentage on administrative or other costs such as salaries. And if they don't comply with those requirements, then they have to basically provide consumers with a refund or a rebate on a certain percentage of the premiums that that consumer paid over the year. And then, of course, there's coverage of preventive services without cost sharing, and that went into effect prior to 2013 and prior to 2014. But the big requirements going into effect this year are really significant, and it's what's been covered a lot in the media in the past few months, and it's what's really been the heart, I would say, of the expansion of insurance coverage in the Affordable Care Act. And that is most new plans, that is non-grandfather plans, can no longer deny or rescind coverage for adults based on condition, disability, health status, or age. So previously, in 2010 and beyond, they couldn't do so for children, but now that is expanded for everyone. Insurers are also prohibited from designing discriminatory benefit packages or setting price based on health status of participants. Also an extremely important provision, and somewhat I would say it's complicated, but it's also controversial, because if price cannot be set based upon health status, then it is possible that premiums will go up for everyone, rather than just setting premiums very high for the sick to disincentivize their entrance into the health insurance marketplace in the first place. And then annual coverage caps on EHB prohibited. So those coverage caps would be monetary. So to give a specific example, so DME, a lot of times you'll find that insurance coverage caps durable medical equipment or other kinds of distinct devices with a monetary cap. They'll only pay up to a certain amount and then won't go over that. Annual monetary caps are now prohibited under the law. We may see that those caps still are in existence in some of the plans across the country, but technically that is illegal and certainly could be challenged based upon the letter of the Affordable Care Act. And then mental health parity applies to qualified health plans. Grandfathered plans, I'm just going to skim over this really briefly. Some of the plans that were in existence before March 23rd, 2010, that's the date of enactment of the Affordable Care Act. If they were in existence then and they haven't made any significant changes between then and now, they continued as grandfather plans under the law. So there may be still some existing plans that do not have to meet the new requirements. But as we saw at the end of last year, many plans are canceling existing products because they don't anticipate that they will be grandfathered in, and they know they won't be able to meet the new requirements. So insurance plans have developed new products that they are selling at the start of this year, and they are canceling many that existed previously. I just skipped over the header here. I just want to say we're moving into health insurance exchanges, and I apologize for going quickly, but there's a lot of information, and I do want to get to some Q&A at the end of this. So the state's role. The state has an extremely important role to play in health insurance reform. So first of all, they can decide what kind of marketplace they want in their state. Their state can run their own marketplace that would be called a state-based exchange, or they can reach out to the federal government for help through the Department of Health and Human Services, or they can just default to the federal government exchange. So either they take all the responsibility and they can get some funding to do so, or they share responsibility with HHS, or they basically ask HHS to run their exchange in entirety for them. And they might have a number of reasons for choosing one or the other. Practically, some states may not have the healthcare infrastructure to run their own exchange yet. Other states may think that politically it just is not consistent with where they are politically, and they oppose the Affordable Care Act, and they don't think running their own exchange is a good idea. And in that case, the Department of Health and Human Services has legal authority to run an exchange for them. The benefit designs. States can base plan benefits on existing benchmark in the states. So instead of a national plan, a national minimum benefits package, which all insurance plans would have to cover moving forward, there will still be a state-by-state minimum benefits package system. So the Department of Health and Human Services, the administration made a decision that it would be too complicated, possibly too political to determine a national benefit package. So those benefit packages moving forward, which all insurance plans will have to mimic, will be based at the state level and will be based on an existing plan at the state level. And then the Medicaid expansion. The Affordable Care Act was written in that the Medicaid expansion would be mandatory. That is, that all states would have to expand Medicaid eligibility to adults below a specific poverty level, regardless of their health status, or they would lose all Medicaid funding. That was how the Affordable Care Act was written. The Supreme Court decision in the middle of last year found that to be coercive and unconstitutional, and said that the Medicaid expansion would only be allowed if it was voluntary, if the state could choose not to expand the new eligibility category but still receive federal matching funds for the remaining existing Medicaid eligible categories. The state also retains a large oversight role. So that means that the insurance commissioners are still extremely important in every state, and so is the Department of Health, so is the governor's office, so is your legislature. The state is being relied upon. HHS is relying on the states largely to do much of the enforcement authority. So that although some of the new requirements are at the federal level, the state will still be overseeing and certifying health plan products and trying to ensure that these new plans now meet the federal and the state requirements. That being said, many of the states are still learning the ins and outs of the law, and they do welcome input from sincere stakeholders. So while many states may have certified or still may be learning the new requirements of the Affordable Care Act, and some of the products existing in the states may not meet all the new requirements, they do welcome input from sincere stakeholders. And what I mean by that is from clinicians, from doctors, from people who know the healthcare system and who are experts in a certain area. It has been our experience that when we reach out at the state level to the Department of Insurance or Department of Health, even in states where the Affordable Care Act is controversial, they welcome information that can help them do their jobs better now that the Affordable Care Act is in place. The federal marketplace is very large, and it's causing massive implementation challenges. I don't think many assumed that during the drafting of the Affordable Care Act that so many states would default to the federal exchange. So the federal marketplace looks like a state exchange. There's no separate rules necessarily for the federal marketplace. The only issue is that instead of trying to serve the constituents in one state, it's trying to serve the constituents in more than 25. So the website, for example, crashes more often than a state exchange. The navigators that need to help people navigate the federal marketplace might have a harder time sifting through all the plans that are on the federal marketplace website, where there would certainly be fewer on a state exchange website. And it's difficult, therefore, to really understand the coverage in the federal marketplace when you're trying to skim through and figure out what plans affect you in what state. And this is just a graphic of where different states are in their determination of what kind of exchange they want to build, whether they want to do it on their own, such as New York, California, Nevada, whether they want to share the partnership or share the responsibility, and those are actually the fewest states, and those are in yellow. And then there's a massive amount of states, as you can see, who are basically operating exchanges through the federal exchange. And now we get down to what's covered, and specifically what's covered as rehabilitation. So the Affordable Care Act mandates that 10 categories of benefits must be covered in a minimum benefits package in any state. And those are listed here, and I apologize, there's a lot of information, so it's squished on the slide. And I've bolded one of the categories that's rehabilitative and habilitative services and devices. So in the federal law, it's mandated that rehabilitative and habilitative services and devices be covered by all new small group and individual insurance plans sold inside or outside of exchanges in 2014 and beyond. But that's as specific as it gets. The federal regulations do not mandate specific services and devices which must be covered under the rehabilitative and habilitative services and devices benefit. Some states have legislated or regulated definitions and scope of coverage, but it's really up to the state, and some states are still in the middle of determining what benefits will be covered, and some states are taking a more hands-off approach, and they're not necessarily legislating or regulating the essential health benefits package. Now that's different in the case of Medicaid as well, and I'll get into that in a little bit. So the idea behind a state-by-state system is that plans operating in any exchange must provide benefits substantially equal to those provided in a state's benchmark plan. So the benchmark is the template. Each state selects a benchmark or defaults to one, and then that is the template by which other insurance plans in that state must act. So once a plan has been certified to meet the new requirements, and that would include coverage of benefits, the plan is a qualified health plan. So to be a qualified health plan in any state, the qualified health plan must basically mimic, to a certain extent, the benchmark plan. That would mean if that plan covers rehabilitation for 30 visits a year, so therapy services for 30 visits a year, then you would expect that a plan in that state would largely mimic that rehabilitation package. If there is something that is required in the law, such as habilitation, that has not been covered by that benchmark plan in the past, then that needs to be added by the state. And although monetary annual and lifetime caps are prohibitive, plans can substitute benefits within the category. They can place visit limits on the benefits, and they can use other utilization management techniques, although some of that is controlled by federal regulation. And we'll get into that as well. The Medicaid expansion. So that is the expansion to the new eligibility group that starts this year. There is no deadline by which states must expand. So if a state chooses not to expand in 2014, that doesn't mean their state legislature couldn't pass a law to expand in 2015 or 2016. 26 states have decided to try expansion to the new eligibility group this year. And because 24 states are not moving forward at this time, that means that the number of uninsured will decrease at a slower pace, with 3 million more people uninsured in 2022 than with the mandatory expansion, and obviously that's an estimate. All existing Medicaid benchmark and benchmark equivalent plans, now called alternative benefit plans or ABPs, must cover essential health benefits, regardless of whether the state chooses expansion. So now we're using the term benchmark plan again, and that can be quite confusing considering that we have an essential health benefits benchmark plan in the private market for the exchanges, and we also have Medicaid benchmark and benchmark equivalent plans. So the name has been switched up to alternative benefit plans. But the alternative benefit plans have pre-existed the Affordable Care Act. That is that states have been able to create specific plans to match to specific populations prior to the Affordable Care Act. What the Affordable Care Act says is that you can use this existing authority state to create a benefit plan specifically for the new population. If you're going to expand to adults over age 19 who are not already eligible for Medicaid because of a disability or other health condition, then go ahead and create a benefit package just for them, and then you can set the limits based upon that population. However, the restriction on that, and somewhat of a nuance to that, is that these alternative benefit plans must cover the 10 essential health benefit categories. That is not a requirement moving forward for the traditional state plan under Medicaid. It is just a requirement for the alternative benefit plans. So let's go ahead and get into some state examples. And I've got a lot of state examples, and it's really made the slide presentation quite massive. So I'm going to skim over some of this, but we will be sharing the slides so that those of you who are interested in specific state examples can review this information after the presentation. So let me give you an example. New York's rehab coverage. New York will set habilitative services at modified parity with rehab services, for example. So their outpatient rehab services looks like 60 visits per condition per lifetime. So let me back up a little bit and tell you where I'm getting this information. Within every state, there's been selected an essential health benefits benchmark plan. Some of those plans, we have evidence of coverage documents. Some of those plans, we only have a survey that CMS conducted last year prior to these plans being certified. New York's coverage we've gotten from the CMS document. That means that some of these visits might have been, visit limits might have been changed when the state insurance commissioner went ahead and certified these plans. But we don't know that at this time, this moment in time. Right now, what we have to go on is the CMS document and then actual plan behavior as the plans in New York start to operate and as they start to expand their networks and as patients start to go visiting doctors that are networked with that new plan. But as I look at that, that inclusion, or that visit limit, the 60 visits per condition per lifetime, I would certainly argue that that looks like a lifetime limit. It's complicated because most of the limits that were meant to be excluded by the Affordable Care Act were monetary caps. So if there was a 10,000 or a 50,000 or 100,000 cap on rehabilitation services over a lifetime, that would be an obvious restriction that would be legal now. But visit limits are still allowed on the annual basis. But one could certainly argue that a lifetime visit limit is pretty much the same as a monetary visit limit and achieves the same goal. And that is that after a period of time, someone would not be able to access that benefit, and it discourages people who might need that benefit from applying for that plan. So we would argue that in New York, if the insurance commissioner has not already done away with that restriction, that the insurance commissioner should seriously think about it in the future. California's rehab coverage. They include physical, occupational, and speech therapy. It's $30 per day copayment in outpatient setting and $400 per day copayment an inpatient setting. That's quite expensive for the inpatient setting, but this goes to show you between the New York rehab coverage and the California rehab coverage, the differences that are in there between the different plans are quite drastic, I would say, excuse me. And I'm going to go to the Texas rehab coverage. The outpatient rehabilitation services is 35 visits per year. The habilitation services are 35 visits per year. We have hearing aids at $1,000 per 36 months. One could argue that that monetary cap should not be allowed. The Pennsylvania rehab coverage, a skilled nursing facility for 120 days per year. Outpatient rehabilitation services, we got 30 visits per year combined for physical therapy and occupational therapy, 30 visits per year for speech therapy. Some of the exclusions, habilitation services are not covered. Private duty nursing not covered. Hearing aids not covered. So I want to emphasize again right now what we're looking at. This is information from the existing benchmark plan that was selected by the state last year. This is information that affected the plan prior to the new Affordable Care Act requirements going into place. Ideally, what we would see is some of these exclusions going away. Habilitation is a very stark example. Habilitation services are now required by law. But in the benchmark plan that the state selected prior to 2014, there was no habilitation benefit, and in fact, it was not covered by the plan at all. So the state would have to, or the federal government, HHS, would have to try to determine a benefit to meet the new requirement. And it's unclear what that benefit is yet. So one of the biggest problems with the Affordable Care Act rolling out right now that we're seeing is transparency. We know what the Essential Health Benefits Benchmark Plan is. We know the plan name. It could be Blue Cross Blue Shield 1000X, just to make up a name. We know, partially at least, what that plan used to cover prior to the Affordable Care Act, but we don't know necessarily what changes the state or HHS made to that plan once those plans were certified. So one of the things that we can start to do and have providers do is if those documents are not readily available at the state level, they could reach out to their insurance commissioners and start asking for specifics. If habilitation was not covered in the past, how is it covered now? If there's no specific inpatient rehabilitation category listed in the documents that are available to us, how do we know what the benefit is? So these are the kinds of questions we need to start asking, and we need to start monitoring the coverage so that these problems, if there are problems, or this information can be more widely shared, it can be better understood. If there are problems with accessing specific benefits, that can be brought to the attention of the insurance commissioner in a state, a governor in a state, a legislature, or it can be brought to the attention of the Department of Health and Human Services. I'm going to go into a little bit more of the other states, but I do want to leave some time for question and answer too, so I'm going to skim a little bit. In Illinois, there's limited benefits for cardiac rehabilitation. It's a maximum of 36 outpatient treatment sessions within a 6-month period and only available in Blue Cross Blue Shield approved programs. The rehab habilitative treatment programs for autism spectrum disorder are treated separately. Habilitative services are covered for persons with congenital, genetic, or early acquired disorders, and the treatment must be medically necessary, not investigative or therapeutic. In New Jersey, habilitation as provided through rehabilitation services are the same as covered, the 30 visits per year. What this is basically saying in simpler language is that in some states where there was no habilitative coverage under the benchmark plan, those states are determining to cover habilitation at parity with rehabilitation. So to give you an example, if New York covered rehabilitation with a 60-visit lifetime limit on OT, PT, and speech, if New York wanted to create a habilitation benefit to match the rehabilitation benefit, they might say, well, we'll cover the same services at the same visit limits. And we'll call that parity, and that's how we'll define habilitation for now. That has been a challenge in our advocacy because it sounds so simple to the regulators, and particularly, I think, to policymakers who don't necessarily have a familiarity with habilitation. Parity sounds great. It's an easy way to match the benefit, the habilitation benefit, to an existing benefit, and they feel it's probably an easy way to meet the new requirement, at least for 2014. Of course, an individual who needs habilitation services is not necessarily going to, their needs are not necessarily going to be met by the same amount of visits as someone who might need rehabilitation. It's really going to come down to the individual. And of course, we'd like to see a medical necessity standard applied for determining limits. But really, it's going to come down to providers in a certain state speaking up where those habilitation limits are matching the rehab limits, and either the rehab limits are sparse and so not good for either benefit, or they might be all right for someone who needs rehab but not really necessarily comparable for someone who needs habilitation, and there may need to be an exceptions process developed for that, and I can talk a little bit about that in the future as well. Excuse me, I'm going to go ahead. The Michigan rehab coverage, as you can see, is quite lengthy in terms of just what kind of information they put into the documents that they're making coverage, or they're making public. I'm not going to go ahead and read all of this, but it would be important for providers in Michigan to look at the exclusions, which are quite a lot. They might be fine, but it would definitely be something that we'd want to look at. For example, cognitive rehabilitative therapy not covered, strength training and exercise programs, which might be all right. Vocational rehab services, they're going to put that in there. Therapy to maintain physical condition for chronic conditions, including CP and DD. I mean, there's all sorts of specific exclusions that have been carried over from the benchmark plan prior to 2014 that we would want to review, and some of those we might want to protest if they still show up in the plans operating in Michigan. And then, of course, with every state, it's going to be a little bit different as it's a state-by-state basis. It's really challenging to try to follow all of this at the federal level. What we really want to do with this is try to educate providers, physicians, physiatrists at the state level to review their own plans, to look at this, and then bring to our attention problems where they see them, and to also advise the physiatrists at the state level on how they can reach out to their own Department of Insurance or their own legislatures to possibly make some changes where there are problems, or just to ask questions to get answers where there's a lack of transparency. So the exchange origin, this is just looking at some of the trends. State-based, we have New York and California. Of the 10 that we looked at for this presentation, the federally facilitated, most of the states. That means that while those states, Texas, Pennsylvania, Virginia, Illinois, Jersey, Michigan, Ohio, while most of those states retain authority, well, all of them retain the authority to review insurance plans, certify them, really they've left a lot of this responsibility up to HHS to try to determine whether or not the plans operating in all of those states meet the new requirements. Decisions on Medicaid expansion. We've got, looks like 7 states that we focused on. They're implementing the Medicaid expansion, while 3 are not moving forward at this time, although I'm sure Virginia is going to be debating it this year. And possibly quite Texas and Florida, I think it remains a hot-button issue for those state legislatures. Just to talk a little bit about the politics of Medicaid expansion at the local level. Well, at the national level, it's largely a discussion around ideology and rhetoric. At the local level, it's a lot about economics. The federal matching amount for the new eligible group is 100% for the first couple of years. And then according to the Affordable Care Act, it only goes down to a 90% over time. So unless that law is changed, the federal matching level for the new eligible group is and will remain quite generous. And it is hard, I think, economically, financially for a state to turn down that kind of help for expanding health insurance to some of their poorest constituents. And when a state doesn't expand, that means that the costs of the uninsured population remain on groups like social services, hospitals, healthcare providers that take the uninsured and swallow some of that cost. So there's a lot of pressure from some interesting coalitions at the state level on governors and on states to expand Medicaid so that some of that cost that have traditionally been borne by the healthcare system can be transferred over to the federal government, who at this point is making a very generous offer in terms of incentivizing states to expand Medicaid. Another group that has to shoulder more of the burden if states don't expand Medicaid are employers. So employers start facing fines starting next year. Large employers start facing fines if they don't offer insurance and their employees go into an exchange and receive federal subsidies. So the idea is if someone's employee goes into the exchange and receives subsidies from the federal government, well, then the federal government is helping that person pay for insurance, when obviously they would prefer the employer to be helping to subsidize that insurance. So when there's a cost shift and the individual receives subsidies instead of going into a large group plan through the employer, there's a fine applied to that employer. Now, in a state that doesn't expand Medicaid, that means there will be more employers who could be subject to these fines. If an employee goes into the exchange and is eligible for Medicaid, they actually are not eligible for subsidies to purchase insurance through the exchange. So in those states that are expanding Medicaid and where that becomes an option for low-income workers, those employers are somewhat insulated from some of the liability of not providing health insurance. In states that don't expand Medicaid, there's more liability for those employers. So what we're seeing is these large coalitions of hospitals, other kinds of healthcare providers, low-income groups, and employers, Chamber of Commerce, these kinds of really broad-based coalitions are starting to put some pressure and have put some pressure in the past on governors' offices who are really trying to avoid expanding Medicaid. States covering greater than 20 outpatient rehab visits per year, quite a few of the ones that we looked at do cover more than 20 outpatient rehab visits per year. It's interesting, the ones that we weren't able to find were California and Illinois, but I would anticipate that as we start seeing plan documents on the exchanges in those two states that we would start to get an idea of what plans are covering. The problem with not having a clear benchmark, not having some website where the up-to-date certified essential health benefit benchmark plans are all listed and all the services are clearly demarcated, is that while we may be getting in individual plan coverage, we don't have something necessarily to compare it to say, okay, well, is it at least above what the benchmark covers in that state? If we don't have that benchmark, then it's really difficult to start understanding the trends. We found that California, Ohio, and New York had a definition of habilitation services included in the benchmark plan, but the definition was not included necessarily in these states, and it was unclear in New Jersey. So some of the documents that we're getting have maybe empty, they'll have a table of all of the benefits. They won't list something at one part of the benefit listing, and then in another area they'll have something called other, and it will say something like habilitative therapy services covered for developmental disabilities, and I think in New Jersey it was also covered for autism, and rehab and habilitative services were covered for those distinct conditions likely because there's a mandate in that state, pre-existing from the Affordable Care Act or existing prior to the Affordable Care Act, but it's unclear if that means that habilitative service limits will also be applied similar to individuals with other conditions, or if the state is trying to restrict, or more likely that the plan had a restriction prior to the Affordable Care Act and was only covering it for certain conditions, but now it will be, it's unknown whether those restrictions have just evaporated with the Affordable Care Act, or if we'll start seeing those restrictions even in the future, and if we'll have to fight those. We've gone through, I've got a number of slides here where we've basically listed out the benefit package, but also we're trying to give you the name, the origin, and whether or not the state is expanding Medicaid in one slide. So this is really just organizationally, we're basically trying to give you more information in different slides so that the stakeholders, the physiatrists in different states have the information in 1 or 2 slides rather than have to go through all of the slides to find information for their state. So I'm going to go ahead and just skip through these. We've gone over many of the information in them, and I'm going to go ahead and get to some of the concluding slides so that way we can take some questions too. So AAPM&R efforts around rehabilitation coverage. PM&R has lobbied successfully for inclusion of rehabilitation and habilitation services and devices in the health reform bill. During the debate, there was a list released of the essential health benefits that would be included in a minimum benefits package. In the first draft, rehabilitative and habilitative services and devices was not there. In the second draft, it was rehabilitative services, habilitation services was included with some work, and then finally the word with devices was added on at the end. You know, some staff on the Hill argued that it was clear that rehabilitative and habilitative services also included devices, but those of us who struggle with device coverage in the insurance world know that it's certainly helpful to have the word device, if not something more specific, in the law of the Affordable Care Act, so that it could not be excluded, that no one could necessarily point to the Affordable Care Act and say, well, it doesn't say device, so obviously it's not covered as an essential health benefit. PM&R also formed an essential health benefits task force to draft a position on essential health benefits moving forward. They've conducted previously a webinar on health insurance exchanges and provided members with tools to advocate for coverage of rehabilitative and habilitative services and devices. And the PM&R remains a very prominent member of the Habilitation Coalition. And that was started shortly after passage of the Act, when it became clear that habilitation was going to be a target as a benefit. And what I mean by that is it's largely misunderstood, and it is largely excluded or just not covered very broadly in the private insurance market prior to now. And so it's been regulated somewhat weakly, in that there's no definition of habilitation at the federal level that plans must follow, and the federal government basically said that if a state doesn't define habilitation moving forward, that insurance plans on a plan-by-plan basis can define habilitation. And that is alarming. And so the Habilitation Benefits Coalition was formed as a way to get multiple clinicians and consumer groups together, create a consensus on what the expectation is for defining habilitation, and really advocating both at the state and the federal level for a meaningful benefit requirement for habilitation. Oh, excuse me. What can you do moving forward? One of the biggest things is just to monitor benefit coverage and network adequacy in your area. Are you noticing that you're seeing more patients? How is reimbursement? How is network adequacy? Are you involved in the qualified health plans? Are you in their networks? A lot of plans, a lot of issuers, I should say, are using existing networks, and then they're just creating new products to sell within those same networks. So it's really important to look to see which networks you're in a state or in a given area, and then to see if those benefits have changed, expanded. Are habilitative services being covered where they were not previously? Are there different utilization management techniques being practiced? Are there longer waiting periods? Are there longer pre-authorization periods? How is the market operating now that these changes are starting to be put in place and that there are new plan products that are operating in your state? Physiatrists can certainly contact state insurance offices to confirm coverage of essential health benefits and establish a point of contact. This might sound intimidating or just far-fetched, but we've done this in some states, and it's actually incredibly helpful. It sometimes requires 2 or 3 phone calls and emails, but eventually we get to somebody who knows something about the essential health benefits package in their state. They likely don't know off the top of their head what the limit on inpatient rehabilitation is or the limits on speech and occupational therapy for a year, but they can look it up and they can get back to you. And if there is not necessarily any language that they can find at the state level to put parameters on a benefit, well, that's when we can offer up some language and we can give an ideal coverage policy for rehabilitative and habilitative services devices. And then a state could take that into account if they're regulating or legislating the package, or if they're just reviewing plans and certifying them that they've met the essential health benefits requirement. And then you can get involved with your state PM&R societies to develop strategies. So obviously, the more people working on an issue, the easier it is to get it done, the easier it is to advocate at the state level, the louder your voice can be. You can share the responsibility and share strategies. So we would highly recommend getting involved with your state PM&R societies if you haven't already. And then, of course, feedback to us, sending emails to Suzanne or Sarah or myself, letting us know how it's going, asking questions where you run into obstacles, and also just giving us information so that when HHS reviews this process in 2015 or 2016, we have the data on hand to show them where they should be making changes. So with that, we've got about 10 minutes left or a little over. I'd love to open it up to some questions. If people want to go ahead and type into the chat window to everyone or to the presenter and give me some questions, then I can read those out and respond. I've got a question, looks like, what about the GMO case? Can we point to that to object to the improvement standard it seems they are imposing in Michigan? I would say not necessarily. We're still reviewing and in conversations with CMS about the changes that they're going to make because of the GMO case, and that is that they're not allowed to necessarily, CMS and Medicare is not allowed to deny coverage based upon the fact that someone will not improve. But they're actually taking quite a, well, I wouldn't say quite a nuanced approach, but they are taking a nuanced approach in that they're still insisting that they can apply an improvement standard for rehabilitative services, where there would be an expectation in certain settings, such as an inpatient rehabilitation facility, that a patient would improve, or else those services are inappropriate. What they are saying is that they will cover maintenance therapy where it's clear that a person would not be able to sustain certain services or get certain services from a non-skilled professional, where they would need a skilled professional in order to basically get the services that they need. So they're not throwing out entirely an improvement standard, but they're basically saying they will cover maintenance therapy in certain settings, but they will still expect that in other settings for other services that they would expect an improvement. That also is for was a Medicare case. Now, obviously, I think that it would be appropriate in Michigan to bring up this case and certainly to bring it to the attention of the insurance commissioner. And I think it's completely appropriate to challenge the improvement standard in the Essential Health Benefits Benchmark Plan. But I would just caution that CMS is still applying an improvement standard, even though they would say they're not. It's nuanced, it's complicated, and they're still making their edits to the manual. Let me see, I think I've got quite a few questions here, so let me just go ahead and scroll down. Is there a way AAPM&R can facilitate advocacy on a state-by-state level? I am an IRF director in New York State and feel that it would be helpful to work with other IRFs in this process. So I think that, yes, there is a way that PM&R can facilitate advocacy on a state-by-state level. We could certainly advise physiatrists at the state level or IRF directors at the state level on who they could reach out to at the state level. We could certainly potentially facilitate interactions with other directors at the state level, or more than likely, I would imagine that we could basically advise as a group those in New York State who wanted to be active on this. So I would say yes, we're doing that already piecemeal, but it certainly could happen in a more organized fashion. Now, how will coverage go if a person has insurance in one state and lives in another state? So multi-state plans are allowed. So insurance plans can sell plan products across state lines, and it really depends on the home state of the insurance plan. If the issuer lives in one state, and I say lives in quotation marks, then they have to abide by that state laws. And if the product is sold across state lines, some of the requirements in another state will not necessarily apply. So the essential health benefits benchmark would be in the home state of the issuer. I'm not sure if that's answering the question. But I will also say that there is something called the multi-state plan program, and I haven't talked about that at all. But at the federal level, the Office of Personnel Management is operating a multi-state plan program. And that program is actually intended for issuers who want to sell plans in all 50 states. So OPM is certifying some very large plans who in 2014 will at least operate in 30 states. But those plans still have to meet the essential health benefits requirement per state. So while it may be efficient to offer a plan in multiple states, and certainly it broadens the consumer base if you sell plans nationally, there's still a lot of individual state requirements that need to be met. So logistically, I think it's been difficult to operate that program when the benchmark plans are set at the state level. But they are, there will be multi-state plan program states. I'm sorry, there are multi-state plans being sold on exchanges right now. Can we obtain copies of the slides? Absolutely. Yes, there's over 50 slides, and I knew I was going to have to skim through quite a lot of information. So yes, I'm happy to share the slides so that people can review them after the presentation.
Also, this webinar is being recorded and will be on the AAPM&R website along with Theresa's slides. So if you have staff or colleagues that you think should participate, they can pick it up on demand on the website.
One thing I think I will add to the slide, Sarah, before I share them is the links to the plan documents that we use to get the benefits. As I was talking through the slides, it's quite complicated, and we had to shorten some of the terms that we used and really use a lot of shorthand when describing what the plans cover and do not cover. So I think if all of the documents that we used are online. So we'll go ahead and link to either the CMS surveys of the plans or the evidence of coverage documents themselves where we have them. so that you can look at the primary document if you find the slide confusing.
Okay, sounds great.
And I don't see any other questions, but if there are questions, just please type them in now.
I think we're good. Thank you very much, Theresa. This has been fantastic.
Thank you, and I hope to do it again soon.
All right, thank you, everybody, and thanks for participating. And we will look forward to seeing you at our follow-up webinars on this series.